Hello, my name is Greg. Mine is Justin. And I'm James. And our evidence based physical therapy project is on cerebral palsy. To start, we'll talk about what cerebral palsy, or CP, actually is. So, it's a neurological disorder that affects movement, muscle tone, and posture. The disorder affects 1 in about every 320 children in the United States. It's caused by damage in the form of lesions in the central nervous system that occurs to the immature brain during development. The damage can occur before birth, during the birth process, or in the years after. On the right-hand side of the slide, you can see some of the specific causes for cerebral palsy. Signs and symptoms usually appear during infancy or preschool years. Typically, less severe cases of CP are diagnosed later in infancy. As gross motor functions and cognitive ability becomes more complex, significant or subtle delays in the normal developmental process become more apparent. In general, cerebral palsy causes impaired movement associated with abnormal reflexes, floppiness or rigidity of the limbs and trunk, abnormal posture, involuntary movements, unsteady walking, or some combination of these. The three characteristics for diagnosis are body movement or posture disorder, a static or abnormality in the brain, and acquired brain disorder early in life. It's important to note that CP is a non-progressive disorder. The damage-causing lesion will not grow, so the neurological symptoms will not progress or worsen. Things that can worsen a person with CP's health are other comorbidities, poor nutrition, lack of physical exercise, or untreated conditions like contractures or osteoarthritis. CP is classified in two ways. The first of those ways is through muscle tone involvement. The most common type of involvement is spastic or hypertonicity of the muscles. So this results in stiff, contracted flexors and results in the typical CP posture of flexed arms, flexed hips and knees, and a scissoring gait. Other types of CP can result from lesions that occur in different areas of the brain, and you can have hypotonic muscles, you can have ataxia, or you can have athetoid CP, where involuntary movements are triggered by attempts to move, usually with turning or rotating. The location of the CP lesion is very important. You can see on the left-hand side, the first line underneath all the different types of muscle tone involvement, that the type of CP that the patient incurs is dependent on where the lesion actually is in the brain. So on top of that, when the lesion damages a certain area, it can also damage other structures in the brain around that area. So a person with CP could also have cognitive impairments and sensory impairments, depending on where the actual injury occurred. That being said, it is a prerequisite for a CP diagnosis that the lesion occur in a motor control area, such as the motor cortex, basal ganglia, or the cerebellum, because one of the three requirements for CP is the effect on movement of the body. The other way that CP is classified is through limb involvement. And it's important to note here that this is specific to spastic type cerebral palsy. So we learned most of these in class, but the one thing that is important to note is that the difference between hemiplegic and diplegic. Hemiplegic is unilateral with an upper and lower extremity, and diplegic affects either both arms or both legs. The reason that spastic CP can exhibit such different outcomes of impairments is based on how large the motor cortex is and how many parts it has. The motor cortex is composed of several parts that are responsible for relaying signals through the pyramidal tracts and down the spinal cord to control movement. Damage to any area of this large portion of the brain can result in varied outcomes, which are reflected in the variety of ways the disorder can present itself in the extremities. Since CP is a non-progressive disorder, the prognosis is actually pretty good, assuming the person has proper care. A person with CP has a normal life expectancy, but can expect to spend that life doing continuous physical therapy, be on medication to include muscle relaxers, pain control, and seizure medication, and will need the help of a caregiver throughout their life. Contractures are common in persons with CP, especially at the hips and knees, and if left untreated, they can result in so much pain and tension on the muscle and the joint that they'll have to be alleviated through surgery through the severing of the tendon. This procedure is called a tenotomy or tendinectomy, where the surgeon will go in and sever part or the entirety of the spastic muscle's tendon. This may be done on wheelchair-bound persons who have a negative prognosis for rehab at the hip joints. A similar procedure can also be conducted to the same effect by removing part of the muscle in order to lengthen it, called a myotomy. In rare cases, fusing bones in the ankle is an option to bypass the negative effects of spastic muscles. When the ankle is fused in a neutral position, it can be made easier for the person to maintain a more normal gait. Not all persons with CP require assistive devices to walk effectively, but those that do will probably be on those throughout their lives, and it's an important goal of physical training and physical therapy to make their gait pattern as efficient as possible. Now that we've talked about what cerebral palsy actually is, we're going to discuss some of the best practiced interventions that are used to treat cerebral palsy.
So for the best practices, we have it in no particular order. The first one would be for the upper extremity, and it is modified constraint-induced movement therapy. So what happened in this study was they constrained the unaffected limb and therefore forced the patient to start using the affected limb a lot more and incorporated task-specific training and goal-oriented planning. So the whole idea behind this was that it's similar to how if you have a lazy eye per se, you put an eye patch over the good eye and therefore force yourself to use the bad eye and it'll eventually balance out. Now they word it as task-specific training and bilateral goal-directed play, but in actuality they just constrained the unaffected limb and had them play around like pirates, actually. So they played around for like 3 hours using their affected limb, and the carryover idea was that they'd start using it a lot more spontaneously. Now they word it as task-specific training and bilateral goal-directed play, but in actuality they just constrained the unaffected limb and had them play around like pirates, actually. So they played around for like 3 hours using their affected limb, and the carryover idea was that they'd start using it a lot more spontaneously. Now the big takeaway from all of this is that in an 8-week follow-up, the effects of treatment were maintained, and it was measured in assisting hand assessment and the able hand kids, and they actually significantly shadowed the control group in results. So this is really effective in getting the patient to use their affected hand a lot more. So the recommended treatment as per the study is 3-hour sessions 3 times a week for 8 weeks. Now it sounds like it's a long time because it's calling it sessions, but they're actually just playing, having fun, playing pirates, and it really gives them a positive reinforcement to physical therapy and really makes it enjoyable for them. So for the next best practice, we looked at incorporating progressive resistance exercise. So what occurred was your conventional strength training program, all your concentrics, isometrics, eccentric movements, but this time around we added functional movements. So the results of functional progressive resistance exercise improves gross motor function, strength, muscular endurance, and it has a goal in mind. So what do you want them to do? Do you want them walking? Do you want them running? All that in mind. So the recommended treatment for progressive resistance exercise is 2 to 4 times a week, alternating days of treatment. Now, intensity is a big one. We want them working at a moderate load. We don't want to overexert them because we're doing a slow, steady, consistent strengthening program. With that being said, so we have them doing 1 to 3 sets of each exercise with 6 to 15 rep range. And like I said, moderate load, so you're going to do 50 to 85% of their repetition maximums. Um, the time, like I said, slow, consecutive, consistent training, 12 to 16 weeks. With that being said, so we have them doing 1 to 3 sets of each exercise with 6 to 15 rep range. And like I said, moderate load, so you're going to do 50 to 85% of their repetition maximums. Um, the time, like I said, slow, consecutive, consistent training, 12 to 16 weeks. So it's important to note that if you're going to do any kind of progressive type of exercise, you want to have a base repetition maximum, whether it be your 1 rep max or your 10 rep max or your 8 rep max, and proceed to slowly strengthen from there. Work within the moderate to high intensity range.
Best practice 3. Task-oriented activities based on neurodevelopmental therapy. Trunk activation in frontal, sagittal, and transverse planes in sitting and standing through facilitation by therapists. In sitting, the activities were reaching and popping of the soap bubble, reaching for a ball in all planes, and transferring plastic rings from one side to the other side of the table. In standing, reaching for the ball to basket in 3 planes was included. Following 6 weeks of intervention, improvements in trunk control, balance, and gross motor function were seen. NDT activities are performed for 6 minutes, with 2 to 3 minutes of rest between activities, for a total duration time of 60 minutes, 6 times a week for 6 weeks. Best practice 4. Backward gait training. Patient practices walking backwards on a partial body weight supported treadmill without the use of other assisted devices. Training focuses on reaching full step lengths, maximizing hip extension, and using reciprocal upper body movements. In children with cerebral palsy, there is moderate evidence that backward gait training improves balance, gross motor function, step length, and walking velocity when compared with forward gait training. Best results occurred when treatment ranged from 15 to 25 minutes, performed 3 times a week for 6 to 12 weeks. Best practice 5. Lower limb progressive resistance exercise. Patients undergo progressive resistance exercise circuits tailored to increasing lower extremity muscle strength. The training load progressively increased based on the child's maximum level of strength, determined by the 8 repetition maximum. 12 weeks of functional progressive resistance exercise was effective in increasing isometric muscle strength of the knee extensors and hip abductors by 11 to 12%. Their 6 repetition maximum leg press strength was increased by 14%. Recommended treatment: 12 weeks, 3 times a week, on a 5 exercise circuit, which includes a leg press and other functional exercises like step-ups.
Now that we've discussed the general best practices for treating CP in a clinical physical therapy setting, we're going to introduce our patient and case study, Justin. He's an 8-year-old boy who was diagnosed with CP at the age of 2. Justin has a less severe case of cerebral palsy. He was diagnosed with declassification type spastic hemiplegia, so his right side's affected, including his upper and lower extremities, although the upper are more affected. He does have a history of spasticity, although he takes injections to manage those. He walks with an assistive device using a front wheel walker. This puts him at a GMFCS level 3. Justin has recently become indicated for physical therapy in a clinical setting because his caregiver had taken on 2 jobs and the home exercise program that they were doing has lapsed, and he now has increased weakness in his right upper and lower extremities, and his ability to walk and maintain balance has regressed. Justin's major performance deficits are apparent in 3 areas: His right upper and lower extremities are weak and lack range of motion in the extensor groups, and that has carryover to his gait, where it causes him extra effort to maintain good posture and proper gait patterns while using a walker due to the weakness in his right extremities. You can see on the right-hand side of the slide how Justin's muscle weakness and his decline in the home exercise program has affected his gait and balance. Justin is below average for his age group and peer group of cerebral palsy patients on the balance scale, time get up and go test, and the 6-minute walk test. These are important issues to address in physical therapy and will be outcome measures for Justin. The following 3 goals are the main focus points for our rehabilitative treatment plan of care for Justin. First, we want to improve his gait speed and quality and his balance while he is walking. The main outcome measures we are looking for are improvements on the Berg Rate of Perceived Exertion Scale to track his perceived walking efficiency, improvements to the Timed Up and Go test as a measure of strength and ability to initiate ambulation, and improvements to the 6-minute walk test to measure ambulatory endurance. Second, we want to improve Justin's right upper extremity strength and endurance of his elbow extensors. These are vital in him supporting his body weight on his front wheel walker. Main outcomes here are a manual muscle test and tracking increases in weight and reps during progressive exercise. Any bonus will be if he starts using his affected limb more often than he does currently. Third, we want to improve Justin's right lower extremity strength and endurance. He has the same issues of weakness with his extensor muscles as his right upper extremity, so we will measure through the manual muscle test and tracking progressive exercise any increases in his ability. Additionally, sit-to-stand repetitions will be trained and tracked as a more specific gait-related measure.
With a little bit of luck and some perseverance, we hope to see Justin's numbers and his measurable outcomes improve. In order to meet Justin's goals, these are the interventions that we will be applying. To prevent falls and improve gait speed and quality, we're using bodyweight supported backward gait training on a treadmill. Justin's recent deconditioning has had the most negative effect on his gait and mobility. Gait training is important, as a specific goal to improve this deficit. Justin would gain the most benefit from backward gait training to improve balance, gross motor function, step length, walking velocity when compared with forward gait training. Secondly, to improve Justin's right upper extremity range of motion, strength, and dexterity, we will apply progressive resistance exercise. Justin's major upper extremity deficit is how the weakness in his affected arm has limited his functionality with sit-to-stands and walking with an assistive device. Justin would benefit from gross motor function strength and endurance training to his right upper extremity to improve both these functions. And finally, to improve Justin's right lower extremity range of motion and strength, we will also apply progressive resistance exercise. Weakness and limited range of motion in the extensors of Justin's right leg has regressed his gait pattern and its efficiency and his ability to transfer from seated to standing. Justin would benefit from gross motor function strength and endurance training to his right lower extremities to improve strength and range of motion.
So here on the left we have the gross motor function classification system. So it ranges from a level 1 to 5 with increasing severity. On the top right we have our training volumes for our desired goals with our training and progressive resistance. So you can see what ranges you would want for different goals. In the middle is the lower extremity strengthening intervention. So they did a circuit of 5 stations with varying intensities with a different goal in mind. So on the bottom chart, we have the guidelines for your predicted 8 repetition maximum. It should be noted that we're not doing 1 rep maximums for these patients because of the risk of injury. So it pertains to their GMFCS levels and gives you a prediction of their 8 repetition maximum.